Assalamu alaikum wa rahmatullahi wa barakatuh. This is Professor Tamir Youssef, a professor of general and endocrine surgery. Today we are going to discuss hernia. Hernia, by definition, is protrusion of a viscous or part of a viscous through a defect in the wall of its containing cavity. For a hernia to be formed, there should be three components: the sac, and this sac should have a covering, and the sac should have a content. So we have the sac, the covering of the sac, and the content of the sac. The sac is a pouch or diverticulum of the parietal peritoneum lining the abdominal wall. It is made up of three parts: the mouth of the sac, the neck, and the body of the sac. The covering are derived from the layers of the abdominal wall through which the sac passes. So the covering is different from a hernia to another. The covering is not constant. The content. The most common content are either omentum or intestine. A hernia containing omentum is called omentocele. A hernia containing intestine is called enterocele. If a hernia contains part or portion of the circumference of the intestine, it's called Richter's hernia. The hernia may contain portion of the bladder, the ovary, with or without the fallopian tube, or it may contain Meckel's diverticulum, and this case the hernia is called Littrus hernia. So any visitor can be found in the hernial sac except for the pancreas. When you are The hernia may be caused by a congenital anomaly like that patent processus vaginalis. The processus vaginalis should be obliterated at birth, but persistence patency of the whole length of this processus vaginalis may be exposed to congenital inguinal hernia, or it may be acquired. This may be caused by traumatic causes or by a disease. A hernia at any site may be reducible. Reducible means that you can reduce the content of the hernial sac. The sac itself cannot be reduced. If you are going to reduce a hernia, you are just reducing the content. You can reduce it by yourself. The patient can reduce his hernia, or it can be reduced spontaneously when the patient lies down. The best one to reduce the hernia is the patient himself. The hernia has four complications. Number one is irreducibility. Number two is obstruction. Three is strangulation. Four is inflammation. So, by irreducibility, we mean that the content of the hernial sac cannot be returned inside the peritoneal cavity. This may be due to adhesion between the sac and the content, as in case of a hernia containing omentum, or it may be due to admission of new content, sudden admission of new contents. The hernia may be obstructed. Obstructed hernia should contain intestine, and this intestine get obstructed. So a hernia containing omentum cannot be obstructed. So the term obstructed hernia should be used only if the content is intestine, and it will be manifested by intestinal obstruction, plus the local signs of the hernia. Strangulation, in which the blood supply or the arterial supply of the content of the sac is compromised or is jeopardized. So, the content here may be intestine or omentum. Both can be strangulated. And if this condition is neglected, the intestine will undergo infarction with subsequent gangrene and perforation. Inflamed hernia is a hernia which is inflamed by either the covering or the content. The covering of the hernia can be inflamed due to unfitted truss, and the content can be inflamed like that hernia containing appendix, ovaries, tubes, or a hernia containing Meckel's diverticulum, the Littrus hernia. If you see this diagram, the above one is a sac containing part of the circumference of the hernia. This is Richter's hernia. This is what? Richter's hernia. In general, a hernia may be external or internal. External hernia will be apparent to the outside or in the outside. Internal hernia is a hernia through internal body opening. The most famous internal hernia is the hiatus hernia, which is herniation of the fundus of the stomach into the chest through the esophageal hiatus. Common external hernias are the inguinal hernia, the femoral hernia, the umbilical hernia, and do not forget the incisional hernia, which is considered the second most common hernia after the inguinal hernia. Other rare types of hernia include the spigelian hernia, gluteal hernia, obturator and lumbar hernia. Spigelian hernia is a hernia through the linea semilunaris at the lateral border of the rectus sheath. Obturator hernia is a hernia through the obturator foramen. It is more common in elderly females. Lumbar hernia, this occur in the lumbar region below the 12th rib and above the iliac crest. How to diagnose a hernia? Number one, a hernia is a swelling at anatomical site of a hernia. Number two, it is reducible. Number three, it gives an expansile impulse on cuff. So again, a hernia is swelling at anatomical site of a hernia. There are known anatomical sites of a hernia. So when a swelling occurs at these sites, you may suspect that it is a hernia. A hernia cannot occur anywhere in the body because it has certain anatomical sites like the inguinal region or the groin. What is groin by way? Groin is an area 1 inch above and below the inguinal ligament. It may occur at the umbilicus, in the epigastric region, and the midline. These are the anatomical sites of a hernia. The hernia is reducible unless complicated. It gives expansile impulse on cuffing when you stand up the patient and palpate the hernia, then ask the patient to strain or to cuff vigorously. You will find that the hernia will enlarge in size at all directions. This is expansile, and an impulse will hit your hand. This is the impulse. So it is expansile impulse on cuffing. If the hernia is strangulated, the expansile impulse of cuffing or on cuffing will be lost and it will be irreducible. So the most important is swelling at anatomical site of the hernia. A hernia is diagnosed clinically. Investigation in a case of a hernia is mainly directed towards the preoperative preparation of the patient. Treatment of a hernia in general includes herniotomy, herniorrhaphy, or hernioplasty. Herniotomy is excision of the sac at the proper neck. How to know the proper neck? By the accumulation of the extraperitoneal fat. Herniorrhaphy, this is repair of the hernia without putting a mesh. Hernioplasty is a mesh repair or using a synthetic material other than mesh like unabsorbable suture material. Now we're going to discuss the anatomy of the inguinal canal. The inguinal canal is a potential canal starting by an opening which is called the deep inguinal ring. This is an opening in the fascia transversalis about 1 centimeter above the midpoint of the inguinal ligament, and it ends at the external or the superficial inguinal ring, which is a triangular opening in the external oblique aponeurosis just above the corresponding pubic tubercle. So if you look at this slide, you will find that above and to the left is the ACEs, the anterior superior spine, and below is the pubic tubercle. So the dark area is the inguinal canal, extending from the deep ring, which is a circular opening in the fascia transversalis, and the external ring, which is a triangular opening in the external oblique aponeurosis just above the pubic tubercle. You can imagine the inguinal canal as a box which has anterior wall, posterior wall, a roof, and a floor, and there is a content inside the canal. Here are the posterior wall, which has the deep inguinal ring situated laterally, and the floor. The roof and the anterior wall are removed. Here are the anterior wall, which had the superficial inguinal ring situated medially, and the roof. So the anterior wall of the canal is made up of the external oblique aponeurosis all through and is reinforced by the internal oblique muscle laterally. The transverse abdominis muscle lies even more laterally as a part of the anterior abdominal wall, so it is higher than the internal oblique. The posterior wall is formed by the fascia transversalis, the orange one, all through, and the conjoined tendon medially. The wall is particularly weak over the deep inguinal ring. The roof of the canal is formed by the conjoined tendon, or better to say, the arching fibers of the internal oblique muscle. The floor is formed by the inguinal ligament. What is the inguinal ligament? The inguinal ligament is the reflected lower part of the external oblique aponeurosis between the pubic tubercle and the corresponding aces. The external oblique muscle in this area is aponeurotic, not fleshy, and the lower part, as I have said, form the inguinal ligament. Actually, the inguinal ligament is formed of three parts. The inguinal ligament proper, which is called Pauber's ligament. The medial part is the lacunar ligament or the gamburnate ligament, and the posterior part is the pectineal ligament or the Pauber's ligament. The inguinal canal in males contain the spermatic cord and the ilioinguinal nerve, but in females it contains the round ligament of the uterus with the ilioinguinal nerve. For inguinal hernia, the male to female ratio is 9 to 1, so it is more common in males. Young adults mostly have indirect inguinal hernia, as direct inguinal hernia occur in the elderly. As the age of the patient increases, the incidence of direct hernia increases. The risk factors: any factor which cause increase in the intra-abdominal pressure can be considered. So we have the chronic cough, constipation, pregnancy, straining at micturition as in PPH, severe muscular effort as lifting a heavy object, ascites, fluid may increase the size of an existing sac. To revise the anatomy of the inguinal canal, as I've told you, you can imagine it as a box. This box has anterior, posterior walls, roof, and a floor. So the anterior wall is formed by the external oblique aponeurosis all through the internal oblique on the lateral side. The posterior wall formed of the fascia transversalis all through and the conjoint tendon in the medial one-third. The roof is the arching fibers of the internal oblique and to this extend the transverse abdominis. The floor is by the inguinal ligament and the lacunar ligament at the medial end. This slide shows the content of the inguinal canal in both males and females. So for the inguinal hernia, it presents with a swelling at the inguinal region. This swelling is reducible and it gives expansile impulse on cuffing. You have to do the special test and the exact diagnosis as will be taught in the clinical round. We have two types of inguinal hernia, either the direct inguinal hernia or the indirect inguinal hernia. The direct inguinal hernia is a hernia passing through the Hasselbalch triangle. For the oblique inguinal hernia is a hernia passing through the internal ring. So the origin of the direct hernia is medial to the inferior epigastric vessel, where that of the indirect hernia is lateral to the inferior epigastric vessels. The content for the direct hernia, the retroperitoneal fat, less commonly a peritoneal sac containing bowel. For the indirect one, it may contain omentum or bowel. Regarding the etiology, direct inguinal hernia is almost always acquired. There is no congenital direct hernia. But for the oblique hernia, it may be congenital or acquired. For the Hasselbalch triangle boundaries, medially is the lateral border of the rectus abdominis. This is the linea semilunaris. Laterally, the inferior epigastric vessels, and inferiorly is the inguinal ligament. Again, if a hernia passes through this triangle, it is called direct hernia. If a hernia passes through the internal ring, it is called oblique inguinal hernia. So in this draw, you can notice the difference between the origin of the direct hernia and the origin of the oblique inguinal hernia. The oblique inguinal hernia, when it enlarges, at first it will remain in the inguinal canal. This is poponocele. Then, with time, it will enlarge and pass through the external ring. This is funicular type. When it is large enough to reach to the bottom of the scrotum, this is complete or scrotal indirect inguinal hernia. For the direct hernia is a hernia passing through Hasselbalch triangle. It is almost always due to weakness of the fascia transversalis. It rarely descends to the scrotum. Rarely descend to the scrotum. And this diagram shows the normal patient and a patient with indirect hernia and a patient with a direct inguinal hernia. And this is again the Hasselbalch triangle, bounded laterally by the inferior vessels, medially by the linea semilunaris or the lateral border of the abdominis muscle, and inferior by the inguinal ligament. This is the red triangle. Both direct and indirect inguinal hernia can occur at the same patient. This is called pantaloon hernia. This diagram showing inguinal hernias. In indirect inguinal hernia, the abdominal content will protrude through the internal inguinal ring. Indirect hernia, the hernia is due to weakness in the fascia transversalis. So the fascia will protrude to the outside. This is direct hernia. So direct hernia actually has no neck. So it is less liable to be strangulated or to be complicated. Complication, irreducibility, obstruction, strangulation. This is more common in oblique inguinal hernia because it has a neck which is at the internal ring, whereas the direct hernia has no neck. Okay, for the management of inguinal hernia, please write after me. We have four types of repair: pure tissue repair, pure synthetic repair, mixed tissue synthetic repair, and darning. So, for the pure tissue repair, here we do not put a mesh, we just repair by sutures. We use non-absorbable suture. The most famous one is the Bassini repair. In Bassini repair, we suture the conjoined tendon to the inguinal ligament by non-absorbable suture. Edward Bassini, which is the founder of this repair, himself was subjected to an inguinal wound during some war in Italy and developed inguinal hernia later on. So he was interested in the treatment of inguinal hernia. But this Bassini repair has three disadvantages. Number one, you are suturing a muscle to a tendon, it will not take. Number two, it is under pressure, and any repair under pressure will lead to recurrence. And number three, it is not physiological because it interferes with the shuttering mechanism during straining. We have another pure tissue repair which is accepted nowadays, which is the shoulders repair. In the shoulders repair, it is a four-layered repair. The first two layers will constitute the fascia transversalis. In this repair, they open the fascia transversalis and suture it in two layers. Then they just approximate the conjoined tendon to the inguinal ligament in two layers. In Bassini repair, they suture the conjoined tendon to the ligament, but in shoulders repair, they just approximate the conjoined tendon to the inguinal ligament in two layers. The second is the pure synthetic repair. Pure synthetic repair is the Liechtenstein tension-free repair. Here, after herniatomy or eversion of the sac to the inside, they put a synthetic non-absorbable mesh, like the Prolene mesh. Then they suture it all around, inferiorly to the pubic tubercle and the inguinal ligament, medially to the linea semilunaris, above to the conjoint tendon. Laterally, a slit is made to accommodate the cord. So the cord will lie upon the mesh. It is tension free, so the recurrence rate is very low. This is a repair using a mesh, but instead of the suture, they used what we call tucker. Tucker is something which is used to fix the mesh instead of the sutures. Here I can see that the cord is passing through the slit made by the surgeon. Here is the classical Liechtenstein tension-free repair. You can see that the mesh is fixed to the inguinal ligament and to the conjoint ligament. Laterally, a slit is made to accommodate the cord. We have two types of laparoscopic repair for a hernia. We have the tip and the tab. The tab is the transabdominal preperitoneal repair, and the tip is the totally extraperitoneal repair. The recurrence rate in shoulders repair or Toronto repair is from 7 to 11%. In Liechtenstein tension-free repair is 0 to 4%. In laparoscopic hernia, it is from 0 to 1%. We have the mixed tissue synthetic repair, in which we do the repair, then we put the mesh either above the repair, it's called overlay, or under the repair, it is called underlay. Then we have the darning. The darning is to fill the space between the conjoint tendon and the inguinal ligament with a non-absorbable suture in all directions. Femoral hernia. What is femoral hernia? A femoral hernia is a hernia passing through the femoral ring to enter the femoral canal. What is the femoral ring? The femoral ring is a ring bounded by the following: anteriorly by the inguinal ligament, medially by the lacunar ligament, and posteriorly by the pectineal ligament, laterally by the femoral vein. The femoral canal is the most medial component of the femoral sheath. So, in femoral hernia, the defect lies in the fascia transversalis, overlying the femoral ring at the entry of the femoral canal. The hernia passes through the femoral canal and present in the groin, below and lateral to the pubic tubercle. This is very important to be differentiated from the inguinal hernia. It is more common in females, especially the multipara females, and femoral hernia is notorious. It is liable for early strangulation. The para-umbilical hernia share the same notorious property. So, for the femoral hernia, a lump occurs below and lateral to the pubic tubercle. It may be reducible, commonly is irreducible. It may not be noticed until it becomes tender and painful, and this is the complication of strangulation. This type of hernia should be carefully sought in obese patients who present with signs of intestinal obstruction without an obvious cause. You should differentiate femoral hernia from Safina varix, enlarged inguinal lymph nodes, femoral artery aneurysm, and rarely a femoral abscess. These are pictures of femoral hernia. You can notice that the hernia is below the level of the inguinal ligament. It can occur both in females and in males, but are most commonly in females. How to repair a femoral hernia? We have three types of repair, either P2B or C2C or P2C2B. B2B is the Lockwood repair or the low approach. You close the femoral ring by suturing the Bobart ligament anterior to the pectineal ligament posterior. We have the C2C repair or McEvedy repair, suture the conjoined tendon to the Cooper's ligament. We have the Luthysen's repair, which is P2C2B, in which we suture the Bobart ligament to the conjoint tendon to the pectineal ligament.